We used structure software, which Neil very graciously showed, so I won't have to spend a whole lot of time on this. We looked. The nice thing about structure is it has a couple different metrics for you to use. One of them is the Dice similarity coefficient, which many people are familiar with. Basically, values close to 1 indicate good agreement, while values closer to 0 indicate poor agreement. You can also look at the percent volume difference between the gold and the individual contours, and also different penalty functions. And the one that we looked at was a penalty with a 1 millimeter forgiveness value. So here's the results of our intra-dosimetrist comparison. So this is just them contouring the same CT scan and repeating it a week later without looking at what they did. And if you look at the overall results, the Dice coefficient in the left column here, you can see they did pretty well. These are all values that are very close to 1. So amongst themselves, they were very consistent of contouring. So dosimetrist A versus themselves, very consistent. So we didn't see that as being an issue. We now look at all the organs that we talked about previously. And starting on the left here are the organs in the head, so the brain, pretty much the list that I showed you a few minutes ago. Here are the organs of the neck, thoracic organs, abdomen, and then finally over here, pelvis. And I plotted here the average DICE score. So this is taking all the dosimetrists, averaging their scores together as a function of the organ. And we outlined in red the ones that you might say need a little bit of improvement. So areas that we thought needed some improvement were the optic nerves, the cochlea, the chiasm, and then over here too, the esophagus and carina. So one of the things that we decided to do was, if you think about it, the organs that they didn't do as well on were organs that typically were smaller. And as you plot here, the average DICE scores with the standard deviation versus the volume of the organ on this semi-logarithmic scale, you can see that the organs having a volume of less than 1 cc tend to do a lot worse than all the other organs that had volumes of greater than 1 cc. And so, for example, the average DICE score was about 0.59 for those with less than 1 cc, which include the chiasm, cochlea, and their optic nerves and lenses, greater than average of 0.9 for all the other organs. And then so here's just the showing a screen capture from structure, looking at the review and training. And so, for example, in this particular case, and this is what you typically see, these greens, reds, and blue. So the blue here is showing where the dosimetrist missed part of the bladder. The red, maybe they over-contoured it a little bit. And so in our first study, we simply had the dosimetrist repeat the contouring on the exact same scan. And interestingly enough, their scores got worse. So as one would, sort of counterintuitive, one would expect them to get better, but in this particular case, it got worse. And there's a couple of reasons for that. One of the reasons is, first of all, for this particular structure, this is just looking at bladder and rectum. The first time around, they all did very well. So it's kind of like you study hard for a test and you get an A, and then maybe you come back later. If you get a very high score, chances are there's only one way to go. You're only going to go down. There's not much room to go up. So I think that's part of the issue. If dosimetrists do well on an organ, why repeat it? Why have them retested? But the second issue, too, is, and it gets a little bit into sort of human psychology, that as someone is looking through the scans, maybe they're trying to memorize where the gold contours were versus trying to understand how their contours differed anatomically from what the physicians drew as the gold contours. So that's an area that certainly needs a little bit of work in for the future as one wants to try to establish this type of program. So again, overall, what we saw is that our dosimetrists tended to score high on initial assessment. The highest scores were generally for organs with volumes greater than 1 cc, which was statistically significant. After training on the same set, the scores were pretty much equivocal or lower. And again, it seemed that the dosimetrists tried to remember where they failed versus understanding why they failed. And then so subsequently, we're going to investigate recontouring on a totally different set of scans so that they're not biased by the previous anatomy. So future directions, reassess. Obviously, we're going to reassess those organs which the dosimetrists did not do well on. Unfortunately, most of them were the smaller organs. So in terms of reassessment, it should be rather easy and not time consuming. Obviously, we have a lot on our plate every day, and the dosimetrists are busy doing planning. So we don't want any program that we design for quality, we want to make it as easy as possible on them. We also eventually would like to include a larger group, and I think an important area where this can certainly make quite a contribution is into training programs. There's a number of training programs within the dosimetry community, a number of universities that are having these programs, and I think to incorporate these as part of training is very important. And finally, to see correlations between contouring metrics and dosimetric endpoints. How good do our contours need to be? And I think some of that will depend upon the dose distribution too. If you have a contour that's in a low dose gradient, it may not have to be as accurate. However, certain things like the chiasm may always have to be extremely accurate because we're so worried about causing complications to that, and they may be in a high dose gradient. So this is something that's certainly an area for future directions and research. And with that, I will turn it back over to Neil.
All right, wonderful. Thank you very much, John. I want to remind people that if you have questions while we're going along, you can use that Q&A section on the right-hand side of the screen to type in any questions. We will have a question and answer section a little bit later on. In fact, what I think we're going to do is after Dr. Wheeler talks, we'll open it up for questions because I know that Dr. Wheeler does have another engagement after this that he needs to be available to. So if you have any questions, start typing those in, and we'll hit those right after Dr. Wheeler talks. So just to keep things going here, what I'm going to do then is I'm going to move this over to Greg Robinson. I'm going to make Greg the presenter here and let Greg talk to us about some of the work that ROR has been doing.
Okay, thanks, Neil. Hopefully everybody can hear me clearly. I'm going to bring up my presentation here. So, like Neil said, my name is Greg Robinson. I work for a company called Radiation Oncology Resources. A lot of you may or may not know who we are. Essentially, who we are is a CMD-based company. We are essentially covering on-site and off-site dosimetry for several clinics all over the country. We're also involved in some clinical training as far as planning and contouring. And so some of our core competencies, involve being very familiar with the latest in technologies and also being very closely linked with the plan challenge and the database of plans and contours that were associated with that. If you're not familiar with the history of the plan challenge, one of our former colleagues, Vicky Lacerba, who passed away a couple years ago, she was a therapist, a dosimetrist, and a physicist. And I know a lot of you, if you've been involved in any of our projects, you've heard her story. But just real briefly, she was really dedicated to not just doing a good job individually, but she had an almost childish curiosity about what other clinics were doing and how to improve quality, not just individually but systematically. She was diagnosed with AML leukemia a couple years ago and passed away. But we continue these projects in her spirit. And so really the offset of the contouring challenge came from the plan challenge itself. The plan challenge was designed to be able to take a data set and allow dosimetrists from all over the world to collaborate different planning ideas, to go over what most clinics feel is important to contour, how they would contour it, and then share those through some educational forums. Ultimately, the way the challenge was designed was to put a single set of CT images out, and then you would have several treatment planners download those images. They then would submit the DICOM RT structure set, the plan set, and the dose set back to us, and we would compare them to a quote-unquote reference plan or gold set, and then analyze the results. And so real quickly, Dr. Wheeler has some clinical responsibilities, so I'm going to fly through some of these slides. The 2009 and 2010 plan challenge involved a head, neck, and a GYN case, and we presented the prescription, and then we would evaluate those plans based on several different criteria, and then we would select quote-unquote winners, and then present some of that information at some different workshops and seminars across the country. Target coverage amongst was probably one of the most important items that we were assessing when we looked at the plans. And this was just some data that we received that's part of the publication that we looked at dosimetric impact of of not only planning but also